So now I'll move on to the next speaker. Our next speaker is Professor Sonoe MASHINO. Sonoe is the director and the professor at the Research Institute of Nursing Care for People and Community, and a professor at the Graduate School of Nursing, Art and Science at the University of Hyogo. She's also the director of the WHO Collaboration Center and works very closely with WHO to strengthen the ability of healthcare workers to deal with medical disaster relief efforts. So over to you, MASHINO. Sonoe, sorry.
Okay, thank you. Thank you, Kevin, for your generous introduction. I'm going to share my slide just a moment. Okay. Hello, everyone. Again, I'm Sonoe MASHINO, the professor at the Research Institute of Nursing Care for People and Community, University of Hyogo. And I'm very delighted and pleased to be invited to speak about disaster nursing works in Japan. So previous speaker, Bettina, also talking about nursing. So again, I'm teaching disaster nursing, so I'd like to introduce what the Japanese nurses respond to the disasters. These are what I'm going to talk about today. So today I'm talking about the disaster relief nurse. So the first thing is who is the disaster relief nurse? So the root of the disaster relief nurse is going back to 1995 at the Great Hanshin earthquake. In Japan, we have a lot of natural disasters such as earthquake, tsunami, typhoon, flood, landslide, volcano eruptions, and so on. The Great Hanshin earthquake is one of the biggest disaster in Japan recent years, which lost enormous human lives and made the worst economic damages. And the highly populated urban area of Kobe city was hit, and more than 320,000 people are displaced. And there were over 10,000 shelters at the peak. And also many healthcare facilities damaged, and we faced urgent need for surgery capacity. So to respond to these needs, nurses from all over Japan rushed to the Kobe city and volunteered to provide nursing care at the shelter, community, and hospital and other health facilities. College of Nursing, Art and Science, Hyogo, now one of the colleges of University of Hyogo, set the headquarters to coordinate nurse volunteers and collaborating with local and national professional associations. So from this experience, nursing associations in Japan developed a mutual support system of nurses by dispatching nurses to disaster-affected area at the time of disaster. We call the nurse as disaster relief nurse. In Japanese, it's Saigai Shien nurse. Nursing Association defined disaster relief nurse as follows: a qualified nurse who is dispatched to disaster-affected area during health emergency in order to provide nursing care for survivors to maintain their health and provide extra support to reduce physical and psychological burden on the nurses who are based in disaster-affected area. So at the time of disaster, many nurses, other than the disaster relief nurse, are also dispatched to the disaster site as one of the members of disaster medical healthcare assistant teams. They are primarily providing medical treatment to disaster casualties with other medical professionals. On the other hand, disaster relief nurses are working at the shelter or community to support survivors' daily livings, sometime at the hospital or long-term care facility to support nurses in those facilities. Disaster relief nurse do what other disaster medical healthcare teams rarely do. So those are examples what disaster relief nurses do at the evacuation shelters. Managing shelters, so assess or triage vulnerable peoples and find out who need care and what they need to and what they and also providing to the care to them and maintaining hygiene and keep a good shelter environment to perform measures to prevent epidemics. And also monitoring health condition of disaster survivors. As you know, Japan is a highly aging society. At the shelter, there are a lot of elderlies in there to be evacuated. So sometimes they already have chronic diseases. So under the environment of the shelter, so it's likely to prevent exacerbation of the chronic diseases. So it's a prevention measure is very much important. So for example, keeping the diabetes patient to keep their medication or a good diet or hypertension, the cardiovascular diseases, those people who have those pre-existing diseases need to be some care for them. And also maintain social well-being of the stress management. And also those elderly need, some elderly need assistance to daily livings. So care and support those elderly to keep their activity of daily livings and also quality of life. And health consultation also provide to pregnant women, adult children, and also disabled. And furthermore, supporting access to the available social services. This is based on the needs assessment, sometimes referral to other professionals or connecting to the relevant resources of the role of those disaster relief nurses in the shelter. Then the next is the disaster relief nurse deployment mechanism, so how they are deployed. For the better understanding of the mechanism, let me explain the Japanese nursing system briefly. Japanese nursing profession consists of the 4 different groups: registered nurse, registered public health nurse, and registered nurse midwife. Those are national licensed professionals and take a national exam and register with the Ministry of Health, Labor and Welfare. We also have licensed practical nurse. They takes a prefectural exam and recorded on each prefecture where they live. Prefecture is the subnational level administrative unit of Japan. We have 47 prefectures now in Japan. And currently, 1.6 million nurses in total are employed, actively working in Japan. And the majority of them are working at a medical facility, such as hospital or clinic, and others at the long-term care facilities, home visiting services, and others, such as community health center, school, and so on. And the Japan Nursing Association is the JNA, is the National Professional Association representing the nursing profession. Nurses get the membership on Prefectural Nursing Association, which is in prefecture where they live, and automatically get the membership on JNA. There are 47 prefectural nurse associations in Japan, and nearly half of the working nurses are members of the association. I illustrated the disaster relief nurse deployment mechanism. Nurse who wish to serve as a disaster relief nurse should register with the Prefecture Nursing Association in her place of residence in advance. When disaster happens, the Prefecture Nursing Association at the affected area collect information from hospitals, local governments, and so on, and assess the need of dispatching disaster relief nurses. Local government may ask for assistance or dispatching nurses. Some Prefecture Nursing Association have a partnership agreement with local government in advance. Based on the extent of impact and the magnitude of damage, the Prefecture Nurse Association activate the disaster relief nurse deployment system. So those are classified the 3 levels. So level 1 is support within the prefecture. So disaster relief nurse within the Prefecture Nursing Association dispatched to the site. And the level 2 is neighborhood support from a neighbor prefecture. And the level 3 is nationwide support. Disaster relief nurse across Japan will come to the site, disaster affected area. So level 2 and the level 3, JNA takes the role of coordination. So JNA requested other Prefecture Nurse Association to dispatch their disaster relief nurse. And the Prefecture Nurse Association, which have a call and called their disaster relief nurse to work, and also sometimes asked the hospital administrator to support them to let them go. And then disaster relief nurse dispatches are determined. 2 disaster relief nurses are paired as a team, and the appropriate number of the teams are dispatched depending on the healthcare needs on the target area. And team makes the daily report and summary of the activity at the end of the mission to the association. Usually one mission period or days of one team are 4 days, and the teams are dispatched by taking turn on duty as long as needed. The needs are assessed by the Prefecture Association in affected area and JNA based on the daily report and actual observation of the situation. So Nursing Association cover travel and equipment expense for dispatching, and also the insurance for any accident. But their works are volunteer, not paid work. So they worked by using their off days, so on. Next is the training and the education of disaster relief nurse. So how to be a disaster relief nurse? The first nurse who wish to be a disaster relief nurse, they require to clinical experience at least 5 years, and also membership of the association, and complete the training courses set by JNA or Prefecture Association. And then the person met those criteria, registered with the Prefecture Nurse Association as a disaster relief nurse. Currently, more than 10,000 in total in Japan are registered as disaster relief nurse. And those disaster relief nurse registered expect to attend the disaster relief nurse meeting and the local disaster drills in the regular time. In the recent years, almost every year, disaster relief nurse dispatch in some way in Japan. So training for them, upon the registration, those training programs are provided. Part 1 is the basic knowledge of disaster nursing. This is a compulsory for registration, and this program, a nationally unified training program, and on-demand online training program developed by and provided by JNA. And the part 2 is a more practical skill training. This is not compulsory, but recommended for registration. Training is developed by each prefecture nursing association based on JNA guidelines. There are other training opportunities. So each prefecture nurse association plans and provides nurses those training courses. And also disaster relief nurses are expected to participate in community disaster drill as disaster relief nurses. Those opportunities reinforce disaster relief nurses' ability to respond to disaster situations. This slide shows the module and the content of part 1 training. Basically, this is didactic lecture-based training. Part is more practical. As education method, tabletop situation-based simulation is adapted. Trainee can get images, what happened at the disaster site, what action they need to take, what kind of decision they would make, and how, and so on in each disaster phases. The next is what challenges we have. Although there are several challenges for disaster relief nurses to act effectively, I'd like to point out 3 of them here. The first one is gap with regular works. Most of the disaster relief nurses work at the acute care hospital in regular time. However, when they served as a disaster relief nurse in disaster area, they are expected community-based work, not the work which they usually do. More public health point of view and primary health care approaches are needed. In general, they are not familiar with those, not developed those competencies through their regular work. The second one is a little recognition of their work and unstable position. This is because the feature of their work, voluntary and limited time. Various medical healthcare teams are engaged in support activity in the disaster area. Lots of interest is given to the team operating under National Institute, such as Disaster Medical Assistant Team, DMAT. However, disaster relief nurses' activities are calm and difficult to get into the limelight. Disaster relief nurses meet the individual daily needs of disaster survivors and the nurses in the area. That's considered useful, but they are not always recognized correctly, so needed to be more visible. The third one is insufficient support from affiliate institution or colleagues. Individual disaster relief nurses are very motivated and engaged. To be dispatched, they might need to negotiate with their supervisors at the work and or the colleague to change their work shift. Right after the mission, they go back to their regular work. Sometimes they experience stressful condition at the site, but what they experience rarely are understood by their colleagues. Disaster relief nurses feel huge gaps with their colleagues. To relieve stress, they need more support from their affiliated institution and colleagues, physically as well as psychologically. The last point is the recommendation for health EDRM workforce development. Again, there are several recommendations, but today I would like to point to the 3 points. First of all, I would like to point out the building a system for dispatching nurses who can corresponding to diverse health living needs of survivors operated by professional associations. I'm sure no one have any objection about nurses are essential worker for healthcare in regular time as well as emergency disaster time. Nursing is the healthcare. Nursing is the biggest health professional group. Have a capacity and the possibility to respond effectively if they are well organized. In many countries, there is a well-established professional association in nursing. So let the association establish this kind of a system. But this system needs to be integrated with a national or subnational disaster response mechanism. In Japan, we're still challenging this. The last one is training and preparing hospital nurses for community-based activities. Many nurses are working at the hospital and they need to be familiar with the skills in community or primary health care. This is the end of my presentation. Thank you very much for your attention.
Thank you very much, Sonoe, for your wonderful presentation. I visited some of the community-based work during my visit to Sendai during the 2015, and was very impressed by some of the setup and for relocating communities after the disaster in 2011. I've not seen any questions from the Q&A yet, but I'm sure they may be coming. So now maybe I can just ask for your insight, because I think with the disaster in 2011, we see the issue with aging population and how it affected, our disaster response. Traditionally, we're looking at trauma, we're looking at injuries, so wound care and operations, or doing plasters and stuff. But now we're looking much more at chronic diseases. Hypothermia was a big issue at that time. And I think mental health, it's one of the major things that we've seen. Maybe can I ask for your insights into how, nurses plays a very important role, especially community nurses. Maybe some insights from your side in terms of how mental health for the elderly, especially because they've lost everything during this disaster. They often relocated. There's not a sense of community in most of the situation. And often their chronic disease deteriorate because of these disruptions in their lives. How do you sort of see, and what nurses can do to support these during these events?
Okay, yes, thank you very much for your questions. Yes, right. Before we are thinking about the disaster response, the disaster medicine, the disaster nursing as a more focusing on the casualties, injured people, care the injured people. But from not only the 2011, but also 1995 also, there are many of the people who are relocated, they have not injured, but they are very much need to be living under the stressful circumstances. And the psychological mental health care is very much important. And so we will perform the PFA and the sites. And the nurses need to know about the PFA also. And for the elderly, actually, but it is surprisingly, elderly are much more stronger than we imagined, because they have had a hard time for the World War II, and they survived those difficult situations. So in my personal experience, so we need to be looking at their strengths, not think about that they are a person who be cared always. So when the elderly have some of the role in the evacuation shelter, they are doing very well. Of course, there are some very vulnerable, very weak elderly have some diseases, but not all elderly are not the same. So one thing is to be looking at the strong point to encourage them to be getting a group or getting reunited the community. So those are very much important. So as a nurse, to try to reach them, to work with them, to encourage them to be work together. This is also the part of the psychological keeping the psychological well-being of them.
Thank you, Sonoe. I think you've raised a very important point, and I think the need for mental health and psychological well-being, it's often neglected or not done well. So I think there's a lot we can learn from the Japanese experience. Just before I go on to next session, we have a question from Professor Robert Cox. He's our founding director. Nice for you to join, Professor Cox. The question was, does the Disaster Nursing Association get any assistance from authorities regarding transport and accommodation for the deployed nurses? So that's a question.
Okay, yes. The Nursing Association supports them to transfer and accommodate, but actually we don't provide any vehicle to them. So it's a kind of one challenge, one of the challenge for us to how to transport them. So it's usually nurses to be dispatched, find out the way to go there. So of course, association help, but it's not directly providing the means to be there. Yeah, thank you.
Another question just coming up about digital triage. I'm not sure whether in Japan you're using RFID tags or like technologies like that. Maybe you can share a little bit.
Okay, it is also discussing, but at this moment we don't have any IT tool to triage or to trace the people who is there and where they go. So this is one of the other areas to be challenged for us. Yes, thank you.
Thank you, Sonoe, and thank you again for sharing your experience. In view of time, we have to go on. Thank you again for joining us.